Thank you for coming and taking time out of your busy schedule to be here today. I'm going to talk about hand hygiene, which is a bit dull, really, isn't it? I mean, I think that's the perception of many of our colleagues, maybe even some of our specialists, maybe even some of us. And I want to try and rethink and maybe even rewrite that narrative and try and make it a little bit more interesting. Now, who has ever been told, well, there's not really any evidence for hand hygiene? Anyone ever heard that? From somebody quite vocally on a ward, maybe? Well, I think we need to push back on that. So, if you were to design the optimal study to really nail it once and for all and say, yep, hand hygiene, really important in improving patient outcomes, how would you design it? You'd have an intervention group and you'd have a control group. An intervention group where you did hand hygiene, a control group where you didn't. Okay, should we try sending that off to a funding agency? Even if it got funded, should we try sending it off to an ethics committee? It's never going to happen, is it? And anyway, the funder would say there's no point because all the evidence is there already. But somebody's done it. So I'm sure you're aware of this already. This is a shocking study. I don't endorse the design. I don't endorse the methodology. I don't even endorse the concept, but the findings are relevant. So a team in America said, what we'll do is exactly that. We're going to pick a group of patients and do hand hygiene, a group of patients and not. And of course, they chose neonates to do this in. And unsurprisingly, what they found is that the group of neonates where hand hygiene was not performed had poorer outcomes in terms of acquisition of bacteria that can be problematic than the patients where hand hygiene was performed. It's by Mortimer and colleagues in the 1960s. It's a blast from the past in a different era. But if anyone gets really tricky, you might have to go there. Now, do we have any Formula One fans in today? Little shy hand at the front. All right, we'll test your knowledge. So, do you recognise this picture? Do you know where it's from? Does anyone know? It's the 1994 German Grand Prix in Hockenheim. And in that car is Jos Verstappen. And it's probably the most dramatic pit fire that there has ever been. And the reason I'm showing it to you today is not particularly because I'm an F1 fan, but because this came from a small error in a little gasket in the fuel supply, a spark, a fire. My point is the result was instant and could have been devastating. Hand hygiene failures, it's a silent, victimless crime, isn't it? I wish every time there was a hand hygiene failure, this happened. Because if it did, we'd be having a different conversation about this subject with our colleagues. So this is the trend in Vienna with Semmelweis in the 1800s, long time ago. I'm always interested to know, there was a little dip earlier, wasn't there? We don't often talk about that. Anyway, there was a clear impact of when the hand hygiene was implemented to prevent the medical staff going from the mortuary to the delivery suite, and the impact was instant. We have a more modern example. You can argue it's not the highest quality study design, but I think the impact is there with the PTA study and the Lancet showing that improved hand hygiene resulted in better patient outcomes. So, hands get contaminated. That can transmit to other patients. If we decontaminate our hands, we can improve hand hygiene and therefore reduce transmission. Okay, so what's the average proportion of hand hygiene in a modern healthcare facility? I need it louder because I can't hear. It's quite noisy in here. Somebody shout it out. What's the average? 40%, 60%. So this review here, the average was 40%, a little bit lower in the ICU, a little bit higher in other wards. We know, for reasons that I think we can begin to understand but don't have time to go into, nursing staff generally have higher compliance than medical staff. And weirdly, compliance immediately before patient contact is almost always the worst. Isn't that strange? Whereas you might think that it ought to be the best. And this is why there's some behavioral science required to understand and unlock this, because there's all kinds of feelings of self-protection that come in to this dynamic of hand hygiene. Because after you've touched the patient, there's a feeling of needing to wash your hands, whereas before you touch the patient, we don't have those feelings. We can't create them, we can't make them, so we have to find other ways to get that message across. I did say I wasn't going to talk about qualitative research, and I almost did. Almost. And yet, if you go to the internet and you download pretty much any IPC annual report, hand hygiene compliance is not 40%. It's not reported that way. And I think we need to ask ourselves why that is, and challenge that narrative in our own heads and in our organizations. These authors certainly didn't believe that this was an accurate representation of hand hygiene. So this is some work that was done on comparing hand hygiene performed by specialist IPC practitioners, auditing that is, and hand hygiene auditing performed by ward staff. And you can see there's quite a big disconnect in auditing done at the same time in the same place. They're measuring different things. So the start of my journey really is to say we need to have accurate hand hygiene data to begin with. So we went on a little journey looking at how to move from a very high reported compliance to what we thought was probably more realistic. So we tried moving from auditing 1 moment to moving 5 moments, still 95%. We tried doing a Control-Alt-Delete reset and re-educating everybody, and still this 95% persisted. So we ended up changing the people who were doing the auditing, and only then did we end up with this, which was compliance reported in the kind of bracket you'd expect to see. Now this was quite a revelation to some, and it was quite a difficult message to say, actually, we want to see lower levels of hand hygiene compliance. Isn't that a strange message to try and transmit to everybody who's interested? But that's where we need to start, because only then can we identify areas that really need more support in achieving meaningful hand hygiene improvement. So the next step of the journey was to look at the improvement work, how to start this, where to start, how to focus. So we've got some great tools. The WHO guidelines from 2009 still very relevant. We've got a Cochrane review. We've got many Cochrane reviews, actually, to pull together all the evidence that's continually ticking through. WHO even have a nice improvement plan that's ready for us to implement. And it includes the sorts of things that you would think would make a difference. But we have to think about local implementation. I think as human beings, if things are imposed upon us, we don't often respond well to that. So I think we need to make sure that any intervention is planned, developed, ideally created locally, because that will lead to sustainability. And that's something really important here. I think if you put in place any of these interventions, singly or in combination, without doubt you'll see an increase in hand hygiene. I think the real challenge is trying to make that sustained over a period of time. And to do that, we need to win hearts and minds. So the third angle and element of the hand hygiene improvement work was to look at the communication, the messaging around hand hygiene. We held some quite insightful focus groups with staff, and the feedback loud and clear was, we don't want to be told that we need to do hand hygiene. We know that already. The stop wash your hands, hate it. Big red signs creates tension, doesn't work at all. What we need is reminders and nudges in the busy workplace to put this up our to-do list. So we went out to a design agency and asked them to help us create a message that would be different, something that's not been done before, something that was focused on the first moment of hand hygiene immediately before patient contact, and something that would not be shouty, but rather make staff think and make staff laugh. And what we came up with was a campaign based on song lyrics. So one of the lyrics that we came up with was this: gel your hands before you go. Huh? And it's been great because it's got people singing, which is nice, a bit Gareth Malone. It's got people thinking, and it's created a smile. We realised, probably too late into the campaign, that we'd gone with lyrics that were all pre-1990s, so we ran a campaign to get some post-1990s lyrics, and we got some good ones. If you like it, then you should have put some gel on it. That was a good one. You and I are going to gel forever. There's also some Elgar in there as well, for those who like that kind of thing. I will say it's been quite polarizing. There are people who don't like this, who would much prefer a more sober message. But when pushed, even those individuals would reluctantly confess that it has made them think about hand hygiene, along the lines of no such thing as bad publicity. So the idea was to try and change the message and the narrative around hand hygiene in order to get people thinking, talking, and singing. And this is what we found. So what you can see there is each line that represents the chart. The big black line in the middle is the mean. Starting in May 18, which was when we began the improvement work with these areas, compliance was around about 40%, which actually by the standards of the review isn't so bad, but that was the starting point. After the initial improvement cycles, we were up to almost 60-70%, and that's perfect. We don't expect this to go any higher. In fact, there's some really useful modeling work that suggests that the incremental benefit of improvements in hand hygiene, once you get to about the 70% mark, isn't worth the effort. And you'd be better off spending resource everywhere and getting up to that level. What's most pleasing, though, is that when the initial improvement work and the cycles were done and completed, the increases continued. So we looks like we've begun to achieve that sustainability that we've been aiming for. Also some work done with individual staff groups, recognising that some staff weren't doing brilliant. And I just want to highlight the therapists here who went from the second lowest performing staff group up to the super performing staff group through mainly an educational intervention that they developed and implemented. And we see, as everywhere else, this difference between medical staff and nursing staff around hand hygiene, which is a problem. Answers on a postcard, please. Across the organisation, I've very cleverly condensed the y-axis here, so that the small increase that we've seen in compliance across the trust is a bit more obvious, but it's creeping in the right direction, and that's good to see. So I think the first step, if we want to really tackle hand hygiene improvement, is to rethink what we're trying to achieve, to begin with meaningful and actionable hand hygiene audit data. Then I do think pick a tool, any tool. I've seen in my brief history that many different ways work and are effective. What's most important is to have something that's locally developed and locally owned and not imposed. And we do need to think about fresh ways to reach staff. The hand hygiene song lyrics were recently launched and they're already tired. So we need to keep moving, keep thinking about what's next. Just finally, before I conclude, a couple of future perspectives of what I think is next. There's already a fair amount of literature and thinking around the role of patients and visitors and non-employed caregivers in hand hygiene. It's a huge opportunity, a huge resource that we're not really utilising at the moment, so we need to think about creative ways that we can include that group. I like the idea of automating hand hygiene compliance somehow. It's never going to replace observational audit. We will need human beings with expertise to actually get on the ward and see what's happening. But I think to augment that process in the background, we are pretty close, I think, to having this kind of technologies that can deliver huge volumes of accurate and actionable surveillance information on hand hygiene to lead our improvement work. And the one thing I hadn't talked about is technique. So in our auditing, we give a very binary, if they've been near a gel, that's okay, we'll mark it as a compliance. But the reality is we need to think about what the process of hand hygiene is when we get there. My own view is that the World Health Organization 6 steps is over-egged. We've got some good evidence with some clinical backing that we could think about a much lighter recommendation around what good hand hygiene technique looks like, but I appreciate that's not everybody's view. And finally, does anybody recognize this group? So this is the medical team from ER. Somebody was sad enough to sit down and watch many, many hours of tape. Was it tape in the 1990s? Anyway. Of ER and do observational hand hygiene audits of ER. Would anyone like to hazard a guess as to what the hand hygiene compliance score was in these audits? It wasn't 0, but it was less than 1%. Oh, come on, don't fail me now. There we go. 0.2%. So hand hygiene is avoided even in fiction. Thank you.